So coming to the journal proper, the aim of this study was to evaluate if providing a geriatric assessment summary with the recommendation for management to oncologists would reduce grade 3 to 5 toxicity based on CTCAE version 4 in patients with aged 70 years and above, starting on a new regimen with chemotherapy and or other agents which cause toxicity for advanced cancers. The secondary aim was to see survival at 6 months and 1 year and treatment decisions as well as geriatric syndromes. The study was conducted between July 29, 2014 to March 13, 2019. It was a cluster randomized trial. They recruited practices from the University of Rochester NCR Community Oncology Research Program, that is UR-NCORP research-based network. The NCORP is a national network in United States which brings cancer clinical trials and care delivery studies to people in the community. The NCORP community affiliates are networks of community oncology practices who receive NCI funding and enroll patients to cancer clinical trials and care delivery studies. The UR-NCORP research base developed practice clusters in collaboration with individual community oncology practices. If an oncologist, coordinator, or research nurse or any other research staff worked at multiple community practices, those practices were grouped into a single cluster. The University of Rochester did not enroll participants by itself, and appropriate approval from the institutional review boards were taken. The patients of enrolled oncologists were eligible, and inclusion criteria was age of 70 years and above, at least one impaired domain in the geriatric assessment, incurable advanced solid tumor or lymphoma, that was stage 3 or 4, ability to provide informed consent, plan to start a new cancer treatment regimen with higher risk of toxic effect within 4 weeks, treatment initiated with a palliative intent, and regimen would have at least one chemotherapy agent or have more than 50% prevalence of grade 3 to 5 toxic effects. The treatment decision was made by oncologist, and he would select the specific treatment regimen, dose as well as the schedule. The randomization and masking. The practice clusters were randomly assigned to either geriatric assessment intervention group or the standard of care group at 1:1 ratio, which was generated by a computer generated randomization table. The randomization was stratified by the practice size. This study evaluated a model of care, hence participants and staff at the community oncology clinics were not masked. Additionally, the statistician who completed the analysis was not masked, whereas all research-based investigators, clinical team members who centrally reviewed treatment and toxic effect of the data were masked. The study groups were geriatric assessment intervention group, where the study team developed geriatric assessment summary, guided management recommendation for intervention, and included cancer treatment considerations. Whereas in the usual care, patients completed the geriatric assessment measures, but summary and management recommendations were not provided to the oncologists. So both the study groups underwent a geriatric assessment. The 8 domains which were evaluated were the physical performance, functional status, comorbidity, cognition, nutrition, social support, polypharmacy, and psychological status. Patients could complete it at home or in the medical practice, and the practice staff would review the measures for their completion and also administer the objective cognition and physical performance tests, and based on which they generated a tailored geriatric assessment summary and management using a web-based platform. At the study entry, the oncologists practices who were under the intervention group received brief training about geriatric assessment, but though they had autonomy for how they wish to use this strategy. The training provided how the geriatric assessment summary could be used to guide treatment decision and how recommendations could be used to guide management of aging-related conditions. Geriatric assessment outcome measures were completed at 4 to 6 weeks, 3 months as 6 months follow-up visits. In the usual arm, the oncologist received alerts only if there were significantly impaired scores on depression and cognition screening tests, and though the summary and recommendations were not provided. The primary outcome was proportion of participants experiencing grade 3 to 5 toxic effect within the 3 months of starting a new treatment regimen. In order to identify this, study coordinators prospectively captured and assessed the frequency and severity of all grade 3 to 4 toxic effect using the NCI CTCAE version 4 and the research-based team, which were masked, reviewed the toxicity grading by comparing the data form as well as the medical records with the medical records. The secondary outcome was the effect of geriatric assessment on treatment intensity and survival. The two masked clinicians would review the patient medical record and treatment regimen, and they used guidelines and clinical trial to determine standard dosing. Proportion of patients who received a reduced intensity regimen were at cycle 1 was evaluated. Similarly, relative dose intensity was calculated, which is the ratio of total dose actually delivered to the standard dose over the first 3 months. The sample size was calculated using data from a toxic effects and intra-cluster correlation among 7 different sites from CARG multi-center study. The design provided 80% power to detect 13% reduction in participants who had any grade 3 to 5 chemo-related toxicity, and accounting for 10% dropout rate. The target accrual was 700 participants. Between group differences in patient characteristics, treatment and outcome measures were measured using chi-square test for categorical variables and t-test for continuous variables. For primary outcome, generalized linear mixed model methodology was applied to account for cluster randomization study design. Here, the proportion of patients who had a grade 3 toxicity was the response. The study group was fixed effect, and practices were random effect. The generalized linear mixed model are extensions of generalized linear models like logistic regression to include both fixed as well as random effects. And these can be used when we have data with more than one source of random variability. For example, if an outcome may be measured more than once on the same person, then this model would be used. Using the fitted model, risk ratio estimates were provided, comparing the proportion of patients who had toxic effects between the two study groups. Effects of intervention on 6-month and 1-year survival was done by Cox shared frailty model. To evaluate the proportion of patients who underwent reduced treatment intensity, generalized linear mixed model was used. The RDI was analyzed using the linear mixed model, and the effect of intervention on geriatric assessment outcome was done by longitudinal linear mixed model. For statistical analysis, SAS version 9.4 was used. Around 900 program components sites were contacted, and 350 components sites agreed to participate. After exclusion, 40 sites clusters enrolled 823 patients were screened. Of them, 733 patients were randomized to either receive a geriatric assessment with the recommendation or geriatric assessment without recommendation or usual care. So coming to the result, a total of 718 participants were enrolled. The mean age of the population was 77.2 years. Here we see that around 70% of the population belonged to the age between 70 and 79 years. Males were present in 56% of them were males, and the non-Hispanic whites were more prevalent in the usual care group compared to the geriatric intervention group. Among the cancer types, we find that lung cancer was more prevalent in the usual care group. That was 31% compared to only 18% in the geriatric intervention group. And among the geriatric assessment, physical performance was the most impaired, followed by presence of polypharmacy and comorbidities. Cognition and social support were more prevalent in the usual care group and in the geriatric assessment group compared to the usual care group. And these differences were significant at baseline. A total of 61% had grade 3 or 5 toxic effects. The grade 3 to 5 toxic effects within 3 months, when geriatric assessment group was compared to usual group, 51% developed toxic effects in geriatric assessment group compared to 71% in the usual care group, and the risk ratio was 0.74, and the confidence interval was showed that this association was statistically significant. The direction of treatment effect was consistent even when robustness of the result with respect to multiple covariates was studied. Coming to the non-hematological toxic effects, around 867 grade 3 to 5 non-hematological toxic effects were recorded. Fatigue and generalized weakness was the most common, followed by electrolyte imbalance and GI disturbances, which was followed by infection reduction and hypovolemia. Only 32% of the participants in the geriatric assessment group developed these grade 3 to 5 non-hematological toxic effect compared to 52% in the usual care arm, and the risk ratio was 0.72, and this finding was statistically significant. Whereas in the hematological toxic effect, decreased neutrophil count was the most common, followed by decreased lymphocyte count and anemia. Though the prevalence was 37% in geriatric assessment group and 44% in the usual care arm, this difference was not statistically significant. This is the bar diagram depicting the same results. Chemotherapy regimen. Most commonly included chemotherapy regimen included either taxanes or platinum-based agents. There were differences in the treatment pattern between the two groups. There were higher proportion of patients in the geriatric assessment intervention group who received less intense chemotherapy. There was single agent chemo was used in 23% of them in geriatric assessment arm compared to 18% in the usual care. Chemotherapy plus other agents were used in 24% in geriatric assessment arm and 18% in usual care. Non-chemotherapy regimens were also more in geriatric assessment arm compared to usual care, whereas doublet chemotherapy was higher in the usual care arm, which was 53% compared to 40% in the geriatric assessment group. Among the chemotherapy agents, we find that in lung cancer, pemcarbo with or without pembrolizumab was around 46% in the usual care arm compared to only 20% in the geriatric assessment arm, and paclitaxel with carboplatin was more prevalent in the geriatric assessment arm compared to usual care. Similarly, in the GI cancer regimens, Folfox was around was used in 35% of them in usual care arm, whereas capecitabine was used in 16% in geriatric assessment group compared to only 2% in the usual care arm. So we see that the regimen selection also was different between the two groups. These are the different regimens used in the genitourinary cancer regimens, cancers, breast cancers, and lymphoma. Coming to the chemotherapy endpoint, which was assessed, reduced dose of chemotherapy was used more in the geriatric assessment arm. That was 49% of the patients in geriatric group, the assessment group received reduced dose chemotherapy, whereas standard dose was used in more in the usual care arm, and the relative risk was 1.38, and it was statistically significant. More dose reduction due to toxic effects over 3 months was more in the usual care arm. That was dose reduction was required only in 43% of them in geriatric assessment group, whereas it was required in 58% in the usual care group. Geriatric assessment intervention had lower RDI over the 3 months. Whereas there was no significant difference between in the assessment of survival at 6 months as well as 1 year. The most common recommendation selected by an oncologist were frequent toxicity checks, adjusting the cancer treatment schedule or dosing, reviewing medication for duplication or intervention, providing education material on age-related condition, and referrals to relevant discipline in the geriatric assessment group. When geriatric domains were assessed at follow-up visits, falls and polypharmacy were the only ones which showed any improvement. That is, there was fewer falls in the intervention groups, and there were greater number of medication discontinuation in the geriatric assessment group compared to the usual care arm. The strength of the study is that it was a cluster randomized control trial. There was higher response rates for patient-reported outcomes. The enrollment, it enrolled a heterogeneous group of population across the United States, whereas the limitations would be that the intervention was done only at a single time point. The autonomy on how they wish to use the intervention was given to the oncologist, so it was not a controlled intervention, and low intensity of intervention and delivery was done by oncologists rather than geriatricians, and this might have limited the ability to improve the geriatric assessment outcomes. The survival was secondary aim and only captured for 1 year, This study was not designed to examine the non-inferiority between the study groups. The population was older adults aged 70 years and above with advanced cancer who were starting on a new regimen of chemotherapy or other agents which cause high toxicity. The intervention was providing oncologists with geriatric assessment summary and recommendation. The control was the usual care, and the outcome which was assessed was proportion of grade 3 or higher chemo-related toxicity. Coming to the critical appraisal, did the trial address a clearly focused issue? Yes, it did. Was the assignment of patients to treatments randomized? Yes, the practices were randomized. Were the groups similar at the start of the trial? Yes, they were. Aside from the allocated treatment, were the groups treated equally? Here I have kept it blank because even though the summary was given, intervention was not controlled. That is, the intervention of referral or other things were left to the autonomy of the oncologists. And were all the patients who entered the trial accounted for, and were they analyzed in the group to which they were randomized? Yes. Were the patients and the clinicians kept blind to which treatment was being received? No, it could not be done here due to the methodology. Was the follow-up of patients sufficiently long and complete? Yes, it was. How large was the treatment effect? The relative risk for chemotoxicity reduction was 0.53. So that comes as a significant treatment effect. How precise was the estimate of treatment effect? The confidence interval was quite small, hence it was a precise estimate. And does these result apply to our patients? Yes, they do. Are our patients different from those in study that its results cannot apply? No. And is the intervention feasible in our setting? Yes, it is. To conclude, in older patients with advanced cancer, geriatric assessment and geriatric assessment guided management integrated with oncology care has shown to reduce treatment toxic effect, falls, and polypharmacy. The geriatric assessment guided management can be considered as a standard of care for older patients with advanced cancer who are starting on new treatment regimen with high risk of toxic effects in palliative setting. Thank you.
Thank you, Abhijith. That was an excellent overview and sufficient time for questions. So I will start. I think, Dr. Mohile, so I think to be eligible for the trial, the predicted toxicity risk had to be over 50%. Is that correct?
For the treatment, the proposed treatment regimen had to have a estimated risk of toxicity of more than 50%. So grade 3 to 5 toxicity by CTCAE. So any chemotherapy would be eligible. For non-chemotherapy regimens. We had to review toxicity profiles based on what was published in clinical trials or approved, through the packaging insert by FDA.
Okay. So some of the regimens, like maybe perhaps hormonal therapy, I think abiraterone and enzalutamide or single agent paclitaxel. So I think intrinsically, we don't think that the toxicity is over 50%, but I think the proof of the pudding is that in the standard arm, your toxicity was 71% for all comers. So that's really
and
something for us.
I don't think Vanitha, that's a good point, but I don't think we allowed any chemotherapy because that was our base bone. It was, this is a frail population. So if you look at paclitaxel in patients who have aging related conditions, the toxicity rates are probably over the rates of 50% in frail populations. If you look at abiraterone and enzalutamide, actually the toxicities are higher than one would expect. I was surprised. So, some of the toxicities are ones that we don't find to be super serious, but they do have a great a prevalence of greater than 50% grade 3 to 5 toxicities. Most grade 3, but patients were eligible.
Perfect. Thanks. So I have lots of other questions, but I think let me any of the residents or anybody else Alok, do you want to unmute and ask?
Ma'am, this is Dr. Abhijith. Ma'am, how the dose reduction was decided? It was based on some specific guidelines, or was it based on the assessment of the physician?
So that's a good question. So in our, so if you pull the supplement for the paper, which is an additional file that the Lancet publishes, there are tables in there that talk about what the recommendations were that were provided to the oncologist for domain impairments. For some of the domain impairments, there was a recommendation to dose reduce by 25% for the first cycle and then escalate as tolerated. It wasn't for all the domain impairments. I think maybe it was for physical performance, functional impairment, and cognitive impairment. And then the reason for that, that's based on some trials, therapeutic trials like FOCUS-2 that's by Seymour et al. For patients with metastatic colorectal cancer, where they found that if you enroll frail older adults and you randomize patients to dose reduction for advanced cancer, the majority of the patients their doses can't be escalated because of toxicity. They have toxicities with the lower doses. And so there was some evidence to support, dose reduction just for the first cycle with escalation as tolerated. So when older adults had impairments on the geriatric assessment domains and those summaries were given to the oncologist could decide to dose reduce if they got that or if they didn't. So they could decide on their own also. We just collected what happened. So we collected their planned treatment options and then what they actually received. And then, and so we looked at the difference of people who, said they were going to plan something before the geriatric assessment and then they dose reduced after it. And so there were significant proportion of doctors of oncologists in the intervention arm who, after they received that information, decided to dose reduce, probably because the frailty was more evident to them when they were looking at the summary of the geriatric assessment. So they decided to be more careful with their treatment. As we all know, the dosing of therapeutic treatments is determined from clinical trials that are done in younger, more fit patients. And so that dosing may not be applicable or the right dose for older patients who have aging-related impairments. And so there is a rationale that the dosing may be over-treatment. So standard dosing is over-treatment for patients who are more frail. So we didn't tell the oncologist what to do. It wasn't that, we just gave them suggestions because it's their patients and they know the patient. They can have a conversation with the patients. But it did provide some evidence for those oncologists to have the assessments to be able to have what likely happened, a conversation about frailty, and be a little bit more careful in that first cycle of treatment. And so what we found was the mechanism was really dose reduction in cycle 1 or in the intervention at the intervention sites versus, okay, people have toxicities and then get dose reduced in the usual care is what we normally do, which if you have older adults who have functional impairments and less resilience, it's probably not appropriate to give them a ton of toxicities up front for advanced cancer. It's better to be a little bit more careful with cycle 1.
Okay, got your point. So basically, it was done that we got the entire detailed reports and assessments, and then the physician themselves decided whether to reduce or not.
I'm sorry, I had a little bit of trouble hearing you.
So it was based on the assessment, physician's discretion that decided.
Correct. Yeah, we basically asked them what they are planning to give their patient, collected that information, then they got the assessment, and then we saw what they actually gave. We got all their chemo records.
Okay.
So we asked them to write down what they were going to get, and then we got all their chemotherapy records and we saw what they actually gave after the assessment was done. So they reduced the treatment based on what they had planned, based on the assessment.
Okay, okay. Thank you.
And the dose reductions are either a 25%, 20 to 25% dose reduction across the board, or sometimes people eliminated certain drugs, you know, or they went, as you could see from the pattern of treatment, sometimes people had planned to give a doublet, but they went to single agent. That's a dose reduction. So they did it in different ways.
So, Dr. Mohile, I guess if we, this is, I think what do you think? So do you think that the reason for the decreased toxicity was primarily the dose reduction in the first cycle upfront? And if that's the case, which we aren't, and I think a lot of centers aren't able to do geriatric assessment for all comers. So if you aren't able to do a geriatric assessment and your sense is that the patient is perhaps frail and maybe PS2 or, you know, doesn't look very robust, would you recommend that we just upfront dose reduce and then evaluate?
I mean, that's a great question. A lot of oncologists have asked me. I don't know, Dr. Narona, if it is related only to the dose reduction. So it could be. We also did all of the geriatric interventions too, or at least asked the oncologist to consider those and have their team implement them. And things like falls and polypharmacy were also improved. So it's hard to know if that was all related to just the treatment changes. My colleagues in Rochester, New York asked me this: do I have to do a geriatric assessment on everyone, or can I just give all my older adults a 25% dose reduction? And, you know, I feel a little bit conflicted about that. I think if in resource limited settings, if you can do a G8 or some sort of short screening test that's more objective than Gestalt or just, you know, a doctor looking at a patient and thinking that patient is frail, I would advocate for that and use that. Even IADL's instrumental activities of daily living, we know, is very predictive of outcome. So I think I would still advocate for using some very short tools to get a sense of function over and beyond, you know, what, you know, the eyeball test is, because we know that the eyeball test doesn't work very well. And if that's the case, yes, if a patient seems frail from those kinds of more objective screening tests, then perhaps dose reducing makes sense. But what we don't want to do is undertreat our fit older adults. And that's what I worry about with just sort of what my colleague has asked me, because I don't think my colleague, who is my boss, actually, and just between you and me, can tell who a fit older adult is from a frail one all the time, just by looking at a patient. I can't.
I was going to say none of us can, I think so.
Yeah, and so that's the challenge. You know, how good are we at just guessing who's frail without implementing some of these tools? There are short tools we can use. I would still advocate for that versus just kind of deciding on our own, because I think in that way we make mistakes. We think people are frail who are not, and we think people are fit are fit when they're not. In United States, I find that a lot of my patients who are Black are considered frail when they're not. So there's bias and discrimination in that way. And so they get undertreated just because people can't assess frailty in patients who are Black. And I think in India, probably that happens with different cultures, people who you may not be comfortable with, different languages, different religions. You know, we all have our implicit biases, and I think it's very difficult for us to sort out our assessments of people in that way.
Absolutely.
Education level is another thing. You know, we can presume someone with a lower education level might be frail when they're not, just because of their education level.
Hello?
Yes. Hello, go ahead.
Yes, ma'am. So my question was, if the geriatric assessment was done for patients who were in the standard of care arm also, like how much information was shared with the treating oncologist, like things like polypharmacy and falls risk, which might have been some, you know, made some difference to even basic treatment?
So that's a really good question. So in both arms, a geriatric assessment was done, and we offered to train the staff at the sites, but it was mostly done by research coordinators that are funded by the NCI, which is our National Cancer Institute. The research coordinators had that information. Most of it was self-reported, and it was questionnaires that were given to the patient, and then the patient filled out those questionnaires. So I'm sorry, I'm sitting in the dark because my family's sleeping, so I look like a shadow. So let me move this a little bit up here. So so it looked like a questionnaire. So the questionnaires were given, and then the tests were done. Sometimes, there could have been contamination, and that information was shared with the oncologist, but I don't know how much it was done. And in fact, I don't think the oncologist knew how to use the information because we didn't organize it in a summary or recommendation forms for them. It was just the raw data from the geriatric assessment that was available in the chart. So they had that information, but I don't think they used it or looked at it, because that's what our results showed. The treatments didn't change. People didn't get the interventions because oncologists aren't really trained in aging, so they didn't really know what to do with it. We did provide alerts, as was described, to oncologists about severe depression or cognitive impairment, because we thought ethically we had to, but we didn't really tell people what to do. We just said, our screening test found that your patient was severely depressed or cognitively impaired, and we let them do what they would do with any patient in practice that they would normally do, but we didn't sort of give them a recommendation for that.
Thank you. If we can just ask another question, like how sure were we that these the doctors on the standard of care arm had like no background on geriatric training or anything of that sort?
Yeah, so in both arms, we collected surveys, and actually there's another paper that describes the oncologist. It was published in JNCCN in 2015. So we actually collected a survey. We surveyed all of the oncologists that participated in both this study and then our other study, which was published in JAMA Oncology. So we had 2 cluster randomized studies of geriatric assessment, and very few of them had any geriatrics training. They all kind of wanted to know more, but almost nobody had geriatrics training. In the United States, we don't have very many oncologists who are trained in geriatrics.
Not in India either, I think.
I know. We had Dr. Yukari Subata from Japan, who's a professor from Shimane, and she was in Rochester rotating with us for a couple of months. And she said in Japan, there's an aging cohort of older adults, as you might know. People are living longer there, and there are much fewer younger people, given the population size differences from India and even the United States. But there's almost no geriatricians, even regular geriatricians, let alone geriatric oncologists. So I think there's a lot of cultural differences in who gets trained in aging.
Do you have a sense as to how many, what proportion of the patients who started at a reduced dose actually got escalated to standard dose? Were there any?
Yeah, there were a few. We haven't looked at that in detail, Vanitha, but we have that because we have all of their chemo records. So there were a few patients that got escalated, and we didn't know kind of how to deal with it later. It's a very few, though, maybe less than 2 or 3% of the patients.
So I guess then the follow-up question is maybe irrelevant. My question is, if they got escalated, did they have more toxicity then, or did they tolerate
that?
Yeah,
we haven't. I mean, we can look at that. We haven't yet, though. But that data is there, and I have a pre-doctoral student who, for his dissertation, for his PhD, is looking at relative dose intensity. So that will come out a little bit in the relative dose intensity work. I think what's interesting about this paper is if you look at the proportion of patients in both arms, what their relative dose intensity treatment is, it was like 63% versus 68%. And so if we think about all older adults getting treatment, if you just looked at even the usual care arm, we're only giving about 68% of the dosing that's recommended from clinical trials. And so the question is, you know, what are we doing? Is it like, are we helping anybody at all? You know, because these trials, the dosing is, you know, set by, that's what is efficacious in the trials. And we're dose reducing so much for these frail older adults. The question is the treatment even useful when we do that?
Okay. Chakur had a question. Chakur, do you want to ask? Chakur, are you there, or you go back to your pretty stuff?
Yes. So there was a network problem. So just one thing, like how much time did it take to assess one patient?
For the geriatric assessment? Is that the question for how much time it took?
Yeah. Yes.
Yeah, so this study was designed in 2012. So at that time, we didn't have a lot of knowledge about which measures in the geriatric assessment were the most reliable, valid, or predictive of outcome. So we actually did a very long geriatric assessment, meaning for physical performance, we did multiple tests, like the short physical performance battery and the tug, timed up and go. We did multiple surveys for function. We did multiple surveys. We did multiple tests for cognition. The patient still did it. And I would think maybe the whole thing together, the patient reported outcomes of surveys may have taken anywhere from 25 to 45 minutes, but we allowed the patients to take the surveys home and do them at home. The tests themselves probably only took 10 to 15 minutes. I wouldn't recommend doing this geriatric assessment in clinical practice. What I recommend is the one in the ASCO guidelines, which is much shorter and still covers all of the domains. We know each of those tests is very predictive now, and the ASCO guidelines were written in 2018, you know, way later than this study was conceptualized. So I don't think you need to do the one that's in the study to make this practical. And again, as Dr. Narona said, you know, if you can't do anything, do a few tests like instrumental activities of daily living or the G8. Those are really good sort of screening tests and correlate pretty well with a larger geriatric assessment.
I think it's almost time for Dr. Mohile to leave us. Any other burning questions from anybody else before we let her get to bed?
If I could ask one.
Please go ahead, Alok.
Yeah. What about immunotherapy? I think it was a small group which received pembrolizumab. So it was like immunotherapy would be safer in elderly, or would that be a preferred option in elderly if given a choice? Is that something that one should?
So immunotherapy was not even, it was a twinkle in our eye when we started this study. It wasn't even FDA approved. As immunotherapy came out, people tried to enroll patients onto the study who were receiving immunotherapy alone. And the toxicity rates for immunotherapy alone are not greater than 50%, as you all know. So patients on single agent immunotherapy or even some double agent chemotherapy agents were not eligible. If patients received immunotherapy with chemotherapy, they were eligible for the trial. And so that was very few patients. I think we're still learning about the benefits of geriatric assessment in immunotherapy. There have been some studies that just came out in the last couple of weeks about, in JAMA Oncology, for example, about how patients who are over the age of 80, they may not have the same number of adverse events, IRAEs, but when they do, they have functional consequences. They have more hospitalizations. They require more supportive care and they don't bounce back. And so it may be that we're looking at how geriatric assessment predicts functional resilience rather than AEs like we do with chemotherapy or other regimens. And so we don't have interventions yet. We don't have a study yet that shows the geriatric assessment model of the care improves outcomes of older adults receiving immunotherapy. But my bet is it's going to be the management recommendations, not the treatment decision making. So it's going to be things like reducing polypharmacy, because a lot of patients who are getting immunotherapy get benzodiazepines and all sorts of steroids, all sorts of other meds that have problems in older adults. And so if we can reduce that, if we can make sure older adults are not calling, that they're calling for, they're calling when they have a problem, then we're going to do better with our older adults. But we don't know enough yet about how geriatric assessment can help older adults on immunotherapy. The studies showing predictive value are just starting to come out.
So it's, I think, Amit is asking, any absolute contraindications for chemotherapy in geriatric patients? This is a loaded question.
So. I don't think there are, there's absolute contraindications for specific drugs that we know about. Like, there's some treatments like hepcidabine you can't give in patients with renal failure, right? So, there are specific contraindications for specific treatments. When I see a frail older adult, I don't ever think of it as, and I don't use the geriatric assessment as a go, no go type thing. I look at all of the issues, and then I use it as to prompt conversation about risks and benefits. And then using shared decision making, you come up with a treatment plan. So I have some frail older adults that really, really want to try cancer treatment no matter what. But as long as they know it's dangerous, and I feel like maybe there's some benefit, I might still adapt treatments to try it. And sometimes I'm surprised, but there are other fit older adults who don't want treatment, and I have to use the geriatric assessment to try to convince them to get treatment because I don't want to undertreat them. And so I use the geriatric assessment as a tool for communication, and that's how I guide decisions and then management. I never use it as a yes, no for anything. It's always a shared decision with the patient and the family.
I think it's just past 10:45 your time, Dr. Mohile. So thank you. Really, this was very, very insightful and very helpful to all of us. So I really appreciate your time.
Thank you for reviewing the study, and good luck to everyone. Thank you for inviting me.
And congratulations.
Thank you. Bye.
Bye. Any other questions from anybody, or we can close? Akhil?
I think, ma'am, we had some good discussions, and Abhijith has covered the study very well. Any other questions from anyone, or?
I think बहुत हुआ.
Ma'am, what is your take on this? Your comments, final comments.
No, I think this is good, yeah. And my gut feeling is that probably we will, or we should be dose reducing older patients. I think we saw this was 20-25% gain study also with, there was a decrease in toxicity. The GO2 study, so they had shown that 60% dose reduction led to improvement in quality of life and did not detract from survival. So no, I think that's what we are moving towards is probably dose reduction to lower toxicity and maintain outcomes. Sorry, is that my connection or?
No, I think there was some distraction.
Yeah, no, but I think this is a very important study, and this at least underlines the fact that all this time, I think that was the main problem, right? That we didn't know. So we all felt that we should do geriatric assessment, but we didn't know whether it improved outcomes. So this very clearly tells us that it improves outcomes in terms of decreasing toxicity for sure. And by and large, whenever we evaluate our patients in our geriatric clinic, we ask them, do you value prolongation of survival or decrease in toxicity and quality of life? So I want to say 60% value improvement in quality of life and a decrease in toxicity rather than prolongation of survival. So this, I think, is a study that shows that we can improve outcomes that are valuable to patients?